So this afternoon, what we want to do is we want to tie the equipment together to all the information that you got from Dr. McKim and the pediatric physician, so that you have an understanding of what the equipment does and the things that it treats related to respiratory care. So the objectives of our talk this afternoon is just to illustrate the breathing problems, and we've really narrowed it down to 4 different areas. The breathing problems that you can run into with progressive neuromuscular weakness, understand what the therapies are available to treat each of those 4, and some of them override each other. Basic understanding on how the equipment works. We can't get into a lot of the details today about each of the pieces of equipment and each of the nuances and capabilities. And there's actually other brands of equipment that are available too. But if you have an appreciation for what the equipment is and what it treats, and you know it may be right or it may not be right for you, then you can walk away with a better informed platform than you had before. So, and that leads me to the last point, is understand the choices that are available to you as a patient. And that is really important. So if you take Dr. McKim's talk this morning, he actually brushed on this. He said, make your decision early, or come up with a plan early, and have a plan, have a respiratory care plan if you are at risk for respiratory muscle weakness in the future. Do it early and come up with a plan. You can always change that plan, and talk to your healthcare providers about your plan. So the 4 areas that we want to really highlight and tag the equipment to is effective cough, maintain effective cough, and this really highlights the earlier talks. Effective cough, maintain effective cough, atelectasis, keeping the airways and air sacs open, ventilation, moving air. Well, it can get complicated, but it really isn't that complicated. You're just moving air in and out of the lungs. And reducing your risk for infection, for lung infection. That's a biggie. And all 3 of those things up above, as I'll talk about in about 2 minutes, actually reduce risk of infection. Effective cough. I think we've got everybody in the room probably has a pretty good idea now from the previous talks. As muscles weaken, so does the ability to forcefully cough. And like non-effective cough will lead to a buildup of mucus and foreign matter in the lungs. When your lung performance decreases because less air gets in and less gas exchange takes place. And Dr. McKim actually talked about it this morning, and I couldn't agree with him more than 100, well, yeah, I could agree with him more than 100%. He talks about the compliance of the chest cavity and the rib cage and the elasticity of the lung tissue itself. So that actually ties into both atelectasis and cough, maintaining an effective cough. So when we're preventing atelectasis, if you take a look at, Dr. McKim had this morning, these air sacs, these are tiny microscopic air sacs called alveoli, and you have millions of them, and that's what makes up your lung tissue. So, and in around the alveoli, these tiny microscopic air sacs are arteries and veins, and those arteries and veins is where the gas exchange takes place. When you breathe in, the oxygen goes down, well, along with other gases, goes down into your air tubes, and finally, at the end of their travel, reaches these tiny air sacs, and then the oxygen gets across the membrane into the pulmonary vessels, and then is transported out to the rest of your body to be used by your tissues. Then when your tissues use that oxygen up, it produces carbon dioxide, it gets back to the lungs through your veins, and it finally ends up into your lungs. And that gas exchange, the carbon dioxide, then goes from here back, or from the blood vessels back into the alveoli, and then you breathe it out. And that's continuously going on. So there's 2 sides to the ventilation equation: oxygenation and ventilation. To prevent atelectasis, those little air sacs that actually are open and have air coming into them on every breath, air in, air out, during atelectasis, those little air sacs actually scrunch up in different areas of your lungs. And it usually happens in the bases of your lungs. So down in the base of your left lower lobe or your right lower lobe, you've seen Dr. McKim's his x-rays this morning where you've seen those white fluffy fields. That was atelectasis that was actually scrunching up of those little tiny air sacs. And when you do that, you're reducing the container availability of the lung. So if the lung could actually each lung could take 2 liters of air, and you've got some scrunching up of those tiny air sacs, now the lung might only be able to take 1.7 liters of air, each lung. So it actually reduces the volume, along with, as Dr. McKim explained this morning, along with the compliance of the chest wall itself. Mucus buildup. If you have mucus buildup in collapsed areas or increased risk of infection and inflammation, double trouble. Ventilation, moving air. I think it was pretty much explained this morning. As your respiratory muscle weakness progresses, you're going to be moving less air in and out of your lungs every minute. When you do that, your carbon dioxide levels in your blood will tend to creep up over time, and your oxygen levels will tend to creep down over time. And as these gases in your bloodstream actually go up and down, your body will try to react to that by telling you to breathe harder and breathe faster. And when you do that, your muscles are going to work even harder. And when your muscles work harder, you could get into muscle exhaustion quicker. And if you don't take care of that as it progresses, respiratory failure will result and you're going to be in real trouble. Infection is the leading acute complication of neuromuscular weakness, and it could result in death if it's not appropriately looked after in a very quick time frame. People can get into, it depends if you're having a lot of problems breathing and you're not on any respiratory equipment and you get an infection, you could actually run into trouble within hours of picking up the beginning of a pneumonia. So you have to be aware of that, have a plan in place, and don't end up as a respiratory emergency in the emergency room, because as other people have noted, not everybody has the expertise, and you could end up on oxygen in the emergency room and be in further trouble. So maintaining respiratory health, the respiratory therapy is available. We're going to tie the equipment to those 4 areas of lung health, or maintaining lung health, and I need a rest. And Jeff mentioned that I'm actually the president of Quality Respiratory Care. That means I'm a policy guy. So I kind of direct policy, and I'm an equipment, or no, I'm a staff cheerleader. And Lori has actually been working with patients day in, day out. The evolution of equipment is so fast that some of the stuff has just come out within the last few months or last several months. And Lori and I are going to go through, she's going to go through each piece of equipment, and I'm going to help her demonstrate it. And then hopefully we'll have some time afterwards to have some questions. And we want people to ask if they're thinking about the need for respiratory equipment in the future, or if you're not happy with the setup that you have now, or you're thinking about something, feel free to ask us. Everybody has an opinion, and you're going to get opinions from respiratory therapists the same way you're going to get opinions from doctors, and it's your job to actually take all that information together and make an informed decision yourself. Lori?
Thank you. Second string. Here we go. Bear with me. All right, so again, coughing. all the time. That's what you got to do. You got to be able to cough, get those secretions out. So early onset of weakening cough, there is a thing, the self-assisted cough, which is in the respiratory care guide that you have. There's also caregiver assisted cough. So if you can't do it for yourself, then obviously your caregiver or your assistant would help you out to provide that extra push to give that cough. So then we have lung volume recruitment and breath stacking. And I know that you saw some video and things today about it. This really is and can be your best friend, okay? Very simple piece of equipment, and what it has is, it is the resuscitation bag, and we have on it not for resuscitation, that is very important. Then there's simply a piece of flex tubing. Inside this green piece is a one-way valve, so that when you squeeze the bag, the air only goes into your patient. The next piece is called a valve trap. So if for any reason the valve was dislodged, it would be stopped at the next valve piece. We have removed the valve. I have a mouthpiece on this. Early on, we like to start people with a mouthpiece, but if things progress, then we can certainly go to the mask. The mouthpiece can be difficult for those that can't do a lip seal, obviously, but then you get into the trouble with the full face mask of providing a seal. And not everyone has the dexterity or the ability to provide a good enough seal so that your patient gets the full benefit of your breaths in, okay? When I teach patients this, it's all about the patient feeling full and they're comfortable, they felt the stretch, they feel that they're able to give a good cough, and it's just teaching, interaction between the caregiver and the patient. You need, as the patient, you need to say, that's not enough. I need more, I want it a little slower, I want it a little bit faster, can you give me a deeper breath, that sort of thing. It's very important that there is that interaction between people, okay? In our company, if we have to explain it, you get new caregivers and you want us to go through it, we do that. We want to make sure that the person that is helping you with the LVR, or if it is you yourself, that you are comfortable with it and that you know how to use it. And Dr. Katz talked about it today about not using it except for an hour after meals. We generally tell our patients to use it before meals so that your stomach's not full, okay? So we'll go back to the presentation, please. Thank you. So it's not available off the shelf. We build it in the office, we get a referral for it, and then we piece it all together. So it has the resuscitation bag with the one-way valve, disposable tubing, mouthpiece or mask, and the do not use. The mechanical cough assist. So we've learned today a little bit more about the cough assist. It has an inspiratory cycle that inflates the lungs. You can use mouthpiece, the exact same mouthpiece on the LVR. You can do the mask, the same mask as the LVR. Or if you are trached, you can use it with the trach. The expiratory cycle deflates the lungs rapidly and moves secretions up the bronchial tree. Start using early, and effectiveness increases with time and experience with it. So that's the same thing as the LVR. We started early, hopefully, and then as time goes on, you get better and better and better at it. We instruct the caregivers, the assistants, as much as possible, whatever they need. If having trouble with pressures, we start low and work your way up to the prescribed settings. So we might start at, say, 20, depending on the patient's size and how the patient's doing, if it's early on. And then my questions again, did you feel full? And are you comfortable with the amount of air? If the answer is no, then we turn the pressure up. And we keep going until the answer to the question, do you feel full, is yes, and do you feel comfortable, is yes, okay? Now the previous pictures of the previous presenters have been the older version of the cough assist, and I'll have to plug Respironics for a minute, and our rep in New Brunswick graciously gave us this equipment to bring along. So this is called an E70, and it works basically the same as the other machine, but the difference with this one is that you can actually put 3 settings in the machine. So that means if in the morning you needed a higher pressure to get you going, you could put that pressure on. Then later on in the day, if you didn't need as much, or maybe you're battling an infection and you need even more, you could put that in and you can actually have a third setting. And the good thing about it is that everything is digital. So you're hitting settings, and it's simple as hit the modify button, and I'm going to change the settings. I hit OK. And you scroll down through. It also has a cough track. The bonus with that is that if you have a low inspiratory effort, the machine can be sensitive enough to pick that up so that it can start your cycle. On the previous models, the auto would just blast the pressure at you. Okay, it didn't matter if you were holding the mask over here or it was on your face. You just got it. With the cough track, you could take it. It won't start until you take your breath in. So you begin your inspiration, and it'll begin the inspiratory cycle, then go into expiratory and go back and forth. Very nice addition. So then you have your inhaled pressure. Then you have an inhaled flow. Your flow can be low, medium, high. So if you like it coming at you at a blast, you can have that. If maybe you're a younger patient, maybe you'd want it on low, okay? Then you have the inhaled time. You can pick, you only want to inhale for 2 seconds, but you want to exhale for 3. This machine has that capability. So we also have exhaled pressure, exhaled time. One other thing that they have added is oscillation. So for anyone that's gotten physio and they've taken and shaken you basically, this is now available on the cough assist, because that's what it is, right? Yeah. So the oscillation, you can have it on inhalation, exhalation, or you can have it on both, okay? Depending on the patient, it's all about what you like and what you don't like. So we work with you endlessly to make sure that we have you comfortable on your settings. So then you have oscillation frequency. How much do you want? And amplitude. How strong do you want it? Okay? So again, find out, are you full? Are you comfortable? Do you like the oscillation? No, I don't like it at all. Okay, we'll take that off. But it just gives you a wide range of options. Respironics, I have to say, did a great job on this, because it is giving the patient themselves a lot more choices for what they're doing with their cough assist. Thank you. I'll show the video. Okay, yeah. Can we go back? Thank you. Can we show the video, please?
So we've got like a 3-minute video
here.
here.
Hey everyone, this is Dawn again.
And this is off of YouTube where you can get more information.
The equipment that I use on a daily basis, because I have congenital myopathy. It's a form of muscular dystrophy. And today I'm going to start talking about my respiratory equipment first. And first of all, I'm going to start talking about my cough assist and how that helps me. Alright, this is my cough assist machine, and I'm going to turn it on, and now set the pressures. And how this machine helps me is I will put this mouthpiece up against my face firmly, and I will inhale as it pushes air into my lungs, and then it quickly reverses, and during the exhale it pulls the secretions out of my lungs. It does this because I have a weak cough, and when I get sick or I aspirate fluids or food into my lungs, this helps get it out quickly. So I'm going to show you how I use this. I go for 1 round, which is 4 inhales and 4 exhales, and then I rest for 20-30 seconds to allow my lungs to rest. And then I do it 4 to 6 more times. That is 1 treatment, and I do it twice a day unless I'm sick. Then I do it whenever I need to. So I'll show you how I do this.
So as you can see right now, she's on the inspiratory cycle. She's taking a breath in, filling her lungs up. She rapidly flips it to the expiratory cycle, and then the cough assist goes into rapid negative pressure and pulls the air right back out of her lungs. And as Dr. McKim said this morning, that rapid transition between inspiration and exhalation actually shears the mucus off the airways and starts pulling it up the bronchial tracheal tree so you can get at it up in your throat.
More times until I'm done. Now I have a good amount of phlegm and
so the machine she actually used was the precursor to this one, and it was an auto. So it had an auto and a manual, whereas this machine is the auto and the manual together, but it's all digital, which makes it easier for people. All right, bi-level positive airway pressure. Gives you a boost of air each time you breathe in, larger volume of air into your lungs. Your options, nasal pillows, nasal mask, or face mask. More advanced machines are available and are being selected by patients that work within a range of pressure set to achieve an average tidal volume. It's helpful because the pressure required to achieve specified breath size changes with body position. Okay, so Dr. McKim was talking this morning about bi-level. So you have an bi-level meaning that you have an inspiratory pressure and you have an expiratory pressure, which will help because the pressure support when you breathe in will help give you a better, bigger breath, making it easier for you to work. So what the next step is, and again, it's Respironics, I'm sorry, they came to our rescue. We have AVAPS, which is called Average Volume Assured Pressure Support. So what we do with that, we take a tidal volume, and it's totally dependent on the patient again. So we pick a tidal volume, 6 to 8 mils per kilogram. So we kind of work in between those ranges, 6 to 8. So we would set the machine up with a tidal volume, let's say 600. And then we set an inspiratory pressure, and we have a min and a max. So if we pick, say, 5 and 20, we're going to open it up wide because I'm going to start you on it. And then we have an exhaled pressure. And we kind of start that low, say at 4, and get you going. What that machine is going to do is that its job is to get you to 600 mils. That's its job. If I am standing up, I get 600 mils. If I lay down, I get 600 mils. If I'm flipping over on my side, I get 600 mils. All the while, the pressure is fluctuating with my change in position in order to give me that 600 milliliters. So your pressure might be at 5 when you're sitting still. But then you stand up, oh, well, I need a little bit of help getting up, so it's going to increase the pressure. It's all about sensing what pressure you actually need to give you that volume. It's a non-invasive ventilation, okay? So this machine here, this is called an A40, and so the 40 is that it goes up to 40 centimeters of water pressure, because again, not everyone requires 20 centimeters of water. There is a range. What it has on it is that this is actually a battery pack, so that this way, if you were being transported from your home into the car and you needed to be on your machine all the time, you have the capability because you have a battery with it, okay? So you can do that. There were days when the AVAPs didn't have a battery with it. You had to have a heavy battery pack, more things to carry when you already have enough. On the other side is a humidifier. All the machines should have a humidity chamber. You want to warm the air that is coming at you, and you want to have a little bit of moisture because, again, one, it helps with secretions. It also makes the therapy more comfortable for you. So the A40, it has the same screen that you see on the E70 and as well on the Trilogy. And we would set it up and try and get you comfortable with it, and then we would carry on from there and change your settings as required. Okay, depending on how you're doing. Dr. Katz was talking about downloading the equipment, downloading the information, and all these machines have a little smart card, just like in your camera. We download it in our computer at work, and we can see. So if I had you wide open on a pressure of 5 to 20, and you're sitting anywhere between 8 and 12, then maybe I would tighten down your parameters a little bit, making you a little bit more comfortable, okay? It also has the option to provide you with a backup rate, and not everybody knows right off the top whether or not they need a little bit of a boost, but when you're sleeping, you might not realize until I've downloaded the card that the machine was giving you a breath. every once in a while at night. That's how deep your sleep was. Okay, so it does have that capability. It truly is a non-invasive ventilator. Thanks. Thank you. So how do we hook you up to these machines? So we have a wide range of masks. And it's a sin because when the clients come into the room, we have this room full of heads with these masks on. I always say, walk into my torture chamber. I mean, come and see my masks because I have a wide array and the eyes are big and you're going to hook me up to that. Yes, yes, we are. But things have changed with the mask, even since I've started in home care. So on this screen, we have a nasal mask. So a nasal mask only goes over your nose. Okay, it does not cover the mouth, only on the nose. It's good for daytime pressure support because there's not a lot of business to it. Also, we try to start off with a nasal mask. If I come at you with a mask that's going to cover your nose and mouth, you're really not going to like me all that much because I'm coming at you pretty hard. So why not try something a little bit small and go from there, okay? So it's small, less cumbersome, and you can talk with some experimentation and practice. You're looking good, Joe. Yes, you can talk. You train yourself to work with your machine if you need it all the time. And you can also even eat, the whole shebang. Okay, so this is a nasal mask. We have a wide array. I would need a suitcase all for the masks that we have. We have different companies. We have ResMed, Respironics, Fisher & Paykel. You can go on the internet and see the mask. The biggest thing about the mask is trying to find the one that fits you and the one that you like and that you're going to wear. There is no point in any equipment if you're not going to use it. And if the mask isn't comfortable, you're not going to put that machine on at night. You're really not, okay? Here's a nasal mask. This isn't, Joe doesn't have the same one. This is actually a brand new one out. We have found that the nasal pillow masks are getting smaller and smaller. The headgear is getting better. So this one's good for daytime because you could wear it all anytime, be out and about. Least obtrusive style, it is. It's the smallest. It doesn't have a lot of headgear to it. Still less cumbersome than a full face mask, and you can still talk and with some practice. So with the pillows, what they actually do is it seals against your nostrils, and that's where the seal comes from. Because every mask, in order for the machine to work properly and give you the pressure that is set and the volume, you need a seal, and that seal comes with the mask. Now, the smaller the mask, like the nasal pillow, the smaller area that you have to seal, which makes it better for you, the less area for leaks, okay? Here comes the full face mask. This is the one people scream as they go out the door. I don't want that, no, stop. But it has its place, and it's good for nighttime sleep. Some people, they use the nasal pillow or the nasal mask during the day, and then when they go to sleep, they put the full face mask on. They don't have to worry about their mouth opening. They don't have to put a chin strap, because that's sometimes what they get into, is that they actually have to put the nasal mask on and then a chin strap as well. Okay, it is difficult to talk with. You can talk. We're not taking away your ability to vocalize. You just have to listen a little bit harder. It is hot and cumbersome. It does provide some problems because, again, the bigger the mask you get, the harder it is to form a seal sometimes. Okay, you have more area to seal, and it makes it difficult. Sometimes if your cheeks are nice and chubby, it's great, but then if you lose weight through your face, it makes it harder to keep that seal. Or people with dentures is another thing. Your cheeks kind of go in. And some people switch between other interfaces and full face. So again, during the day, maybe a nasal mask, and at night, they put the full face mask on. Now, this is a hybrid. This one's a little bit more technically challenging for me. I admit I have a difficult time trying to fit this on very many people. So what it has is a nasal pillow, but it also covers the mouth. So again, you don't have to worry about your mouth opening. And you have the nasal pillow system, but it is technically challenging. There is no pressure point on the bridge of your nose, because you're totally not even going on your nose, which is great. It is difficult to talk with because if you start talking, you break the seal. So if you're on your machine and you're trying to talk, then you're losing your pressure and your volume out. And some people do the same thing. They switch between interfaces and the hybrid mask. So maybe the nasal pillow, the nasal mask during the day, but then this particular mask at nighttime. You've never looked so good, Joe. So then we get into, so the other thing, non-invasive ventilatory support, home ventilator with non-invasive capabilities. So this is the trilogy. Now I'm used to, when I used to work at the St. John Regional, I had this nice big machine and had all sorts of buttons and things like that, and it was very busy. And then I come to this nice little machine. But a ventilator is a ventilator. And what the A40 can do, the trilogy can do, and more. The nice thing with the trilogy is that, and that's the name that Respironics has given, same as the LTV from other companies. So this machine as well has the ability to do non-invasive and invasive, okay? Can use mask interface, so any of these masks will fit with this machine. Or you can do mouthpiece ventilation, either with a mouthpiece or the sipper straw. And many muscular dystrophy patients who require long-term ventilation choose non-invasive, use mouthpiece or straw during the day, and maybe a mask while sleeping. Okay. Now, the ventilator, we work with occupational therapy or whoever is involved in the patient as far as the wheelchair to get the ventilator on the back of it so that it makes it easier for the patient to, if they need the ventilator during the day, to zip around. Uses a mouthpiece or straw as an interface, position on the side of the mouth. Respironics has come out with an arm so that it can sit right here and you just turn your head and you can take your breath. We have a picture of that. It's good for daytime ventilation. Take a booster breath when you like it. Non-obtrusive, but does require good neck movement and ability to lip seal with the mouthpiece. So this is the sipper straw that we have used. It's almost like the suction that you see at the dentist's office. Okay, and then the other one, this is the mouthpiece. Now again, this is Respironics equipment. I'm not plugging Respironics, I'm just saying that this is the equipment that we are the most familiar with, and this is what we're using for our clients in St. John. Okay, and this is the mouthpiece here. So the Trilogy itself is a lovely machine. The bonus with it is that one machine can do both. So if you wanted mouthpiece ventilation during the day, you can have that. And then at night, you can have AVAPs, if that's what you want, and you want to put your mask on, one machine, one purchase, one rental, that sort of thing. Very nice that way. You can have two settings. It's kind of like the Cough Assist that had 3 settings. The Trilogy has 2 settings, primary and secondary, but they can be 2 totally different things, but yet you're getting kind of the best bang for your buck, okay? And the best treatment. So here's the SIP ventilation. It is OT approved, if there's any OTs in the audience. The armored circuit to keep the mouthpiece in correct position, and that's the mouthpiece setup, but also has the straw. So that black piece is very malleable, so you could put it whatever way that you wanted it. If you want your mouthpiece always to be right in front of you, you can do that. If you want it to the side and just turn your head, that is available as well. And there's a SIP ventilation. You want to do the video? Yep. Can we do the video, please?
Hi, my name is Melissa. I am 39 years old, and I have limb-girdle muscular dystrophy. And I have been pretty much in respiratory failure since 2001, and it's now November of 2011. And I chose to not do anything except for nighttime BiPAP since 2001. My body has pretty much accepted that the breathing wasn't as good. But here in the last probably year, I've noticed that it's been quite bad. and I've had to lay down a couple of hours a day. So that was just not really good for the lifestyle that I have. So I did a lot of research, and I was totally against getting a tracheostomy for a ventilator. Not that it's not right for some people, but I just felt like with all the research that I'd done, it wasn't really right for me. So I was looking for different alternatives. And I'm from the Kentuckiana area in southern Indiana, and there's not really anything other than the trach that's sort of available for us. And I looked around and found the non-invasive breathing assistant ventilators, which is more or less just a ventilator that is normally connected to you through a tube in the neck, the trach, but instead of that, the tube comes around and it is on a mouthpiece, and you trigger the machine to take breaths for you when you need to. I would like to do a few videos that would help other people be able to see that this is available for people that has neuromuscular diseases, and they may not necessarily need that invasive ventilation. And I just recently got the ventilator, and it's actually already showing signs that I'm not as nearly as fatigued as I am. Right now I'm pretty short of breath because I've been talking and I haven't done it. So I will now show you kind of what I do. Here we have the stand that holds the hose. To my right, maybe it'll be on your left, I'm not for sure. And the hose just feeds up through on a stand that's connected to my wheelchair. And that stand is actually a microphone stand, which they work perfectly. There's not really a medical device out there that would do the same thing, that would hold that for you. So we purchased the microphone stand, and it works pretty good so far. So anyway, when I want a breath, all I do is lean over and place my mouth on the mouthpiece, and I take however many breaths that I want to. So I'll demonstrate that now for you. Now, there it was. I took about 3 or 4 really good deep breaths, and it helps me fill my lungs to the volume that it needs to fill, and it helps me to breathe a lot better and not be as fatigued. So you can either have it here in front of you, or it's easily gotten to, or I nudge it with my head out of the way like that, or however you're most comfortable with. There's many different ways that you can use to hook the mouthpiece around to your mouth. I've chose this way because I am a little bit more mobile with my shoulders and head moving. I'm not able to lift my arms, but I can use, a little bit of my head and mouth to be able to grab a hold of it. So I look forward to doing a few more of these videos, to showing you more how I do it in the back, and my husband will help with that. Thank you.
Thank you. Okay, Joe's going to invasive.
Lori and I discussed about, we were trying to figure out how we were going to present this. What part of the lecture do the talk do you want to do, and what part am I going to do? And Lori said, you know what, when it comes to invasive, you need to talk about that, because I don't want to go there. And you can see from Dr. McKim's discussion this morning, there is, he calls it a paradigm shift. When you're trying to get the medical community to start thinking about, hey, maybe this non-invasive technology it's pretty good now, and people have a pretty good quality of life without being introduced with a tracheostomy and invasive ventilation. And just before I go into like a 1 minute on the invasive ventilation, I want to say we chose that video of the lady to talk to you about the mouthpiece ventilation, because she just expressed just about what everybody who has a muscular weakness disorder goes through. I couldn't find the equipment available in my community. I couldn't find the expert that was available that could give me the options. I had to go and do research. I figured out through all the research that maybe non-invasive was right for me. Then I had to figure out what was available in non-invasive, who was going to look after my machine for me. These are all the things that everybody goes through when they start making a plan for respiratory care, and that's why it's important. If you talk to your doctor and you anticipate getting into respiratory muscle weakness in the future, or you are beginning to experience muscle respiratory weakness, develop a plan. Figure out where your resources are in your community, find the specialist, figure out what your options are, talk to your family, and put it down on paper and communicate it with everybody. It'll be the best thing you've ever done, because if there is an urgent problem in the future, perhaps you pick up a pneumonia or just the flu bug in the wintertime, you could get into trouble really, really quickly. And if you have that plan in place, there you go. If you don't have a plan in place, we've seen it too many times where people have ended up in the intensive care unit, trached and ventilated, and they didn't want to be there. They wanted to be on non-invasive ventilation, or they didn't want any respiratory care intervention. It happened in St. John 8 months ago. So invasive ventilatory support, tracheostomy and ventilator. Dr. McKim explained pretty good this morning what it involved. It involves a surgical incision into the neck. It's usually a relatively easy surgical procedure to do. Once you have that done, you'll actually end up in the intensive care unit of your hospital. They'll put you on a ventilator. They'll tweak your ventilator settings over a period of a few days to get the right settings for you. And then it's a matter of being transitioned from hospital back into the community. That is where the trouble usually exists. In some areas, there is a great program in place that will actually get the patient onto a home care ventilator in the ICU setting, get them out onto the floor, or get them discharged to the back home. In other areas, it tends to be weeks and months. And funding comes into play, the available resources in the community, the companies that are available, what they provide comes into play. So if you have that plan together, and you get into that situation, it will go all the much smoother and all the much faster. I don't have any evidence here today with me, but the longer you stay in the hospital, more chances are you're going to pick up an infection. I didn't say that. The reality is, actually, if non-invasive ventilation is right for you, either through SIP ventilation with the mouthpiece or the straw, or using the mask, and if you require ventilation substantially most of the time, you could change it up between the SIP straw during the daytime and then go to the mask at night. Obviously, if you're sleeping, you're not going to be able to reach for the straw. But for some people, invasive ventilation is the only choice. Perhaps severe bulbar palsy, which is the weakening of the muscles in around the neck, and your speaking and swallowing muscles have severely weakened, and if that happens, then you may have difficulty using SIP straw or mask ventilation. The reality is, if you choose invasive ventilation, it tends to be more work for you and more work for your caregivers and attendants and family. Dr. McKim, in the adult breakout session this morning, had one great line. And he said, a colleague of mine told me a little while ago, when I trach a patient, I don't trach a patient, I trach a family. Because it takes the entire family to now provide the care for the patient. So it requires a higher level of care. There's a lady that actually has the Trilogy ventilator in the background, and it's on a circuit here, up to a tracheostomy in the neck, and then she has her E70 cough assist handy as well. Might I say that we have Respironics equipment, well, with some ResMed equipment here today, but there are other options out there. It depends on the company that you work with. For instance, Ventilator is Canada-wide. They actually use the laptop, the LTV ventilator. It's a great little device. Most of the ventilators today will actually do bi-level positive airway pressure support, will do invasive ventilation, non-invasive ventilation. They do it all. So one of the things that Lori and I were, when we were coming up here on the plane, we were going through our notes, and we were trying to come up with a statement, and this second one right here says, explore your equipment options and choose what will work for you now and will also meet your future needs. Some people may start early and they go on to a bi-level machine. Then their respiratory muscles continue to weaken. Then they have to advance onto something else. They have to then get into a ventilator. And they may even have gotten like a $3,000 bi-level machine up front, use that for a year, then had to go to a more advanced bi-level machine, perhaps the A40, which is probably, I don't know what they are in this area, but $7,000 or $8,000. And then they use that for a year, and then all of a sudden they need a ventilator. Well, Lori and I got talking on the way up, and we said, why don't we just tell the crowd exactly what we think? Here's what we think. If you think you're going to be requiring ventilation in the future for a long time, don't go with a $3,000 BiPAP. And if you think your ventilation is going to get worse, and maybe non-invasive is only going to be for you, buy one machine. Don't go through three. We just want to leave you with that word of advice. Talk to your suppliers, get information, figure out what your plan is, what the machines will do for you now, and what they will do for you in the future as your respiratory needs may increase. The main thing is the equipment must match what you're trying to treat. So maintaining effective cough. That is, before mechanical cough assist, you use your self-assisted techniques that you've been trained to do. Prevent atelectasis. Your cough assist will help you prevent atelectasis. Your lung volume recruitment device, your LVR, is your best buddy. That will help you with everything. That will help you maintain, reduce the atelectasis, maintain the compliance of your chest wall, and it will actually help you to some degree with your effective cough, especially if you're doing those self-assisted cough techniques. And maintaining ventilation, now you're into the BiPAP or advanced BiPAP device, bi-level devices, and or the home mechanical ventilators. And minimizing risk of infection. If you do all of those interventions, you keep your lungs healthy, you keep them inflated, aerated, reduce the risk of atelectasis, and follow advice about staying away from concentrated forums like this one. Sorry. If you take precautions to minimize the risk of infection, then you're actually going to increase your chances for a very good quality of life well into the future. Thanks for the opportunity. We'd love to hear some questions or comments. And if you want to talk about the equipment or the intervention, what you think might be right for you. If you don't want to do that in a public forum, please come see us. There's actually 4 respiratory therapists sitting at that table with a vast amount of experience. Erica, Ashley, myself, and Lori, and we'd love to sit down and talk with you about your needs and what we want you to come away from this forum with more information that you came here with.
So I think we'll open it up to questions now. Anybody have any questions for Joe or Lori? Right here in the middle.
How long do most ventilators last then? You were talking about be smart about purchase.
Yeah, that's an excellent question. Most ventilators, they require preventive maintenance, PMs, and depending on the company, they require, it's usually like 1,000 to 2,000 hours. Now, if you're talking about a ventilator that's running 24 hours a day continuously, that's about a year. So the ventilator is still going to be working after that year, but usually they have to go in for preventive maintenance. So you need to talk to a supplier that's actually going to treat you well and give you what we call a loaner ventilator while yours goes back to receive preventive maintenance. Very important, so that they have an equipment pool that they can switch out with you. Usually the overhauls in ventilators will come, depending on the manufacturer, anywhere between 2,000 to 4,000 hours, so 2 to 3 years. A ventilator that receives regular preventive maintenance and overhauls according to a schedule will last for several years. I can't give you a 10 to 15 year thing, but I can probably say 5 to 10 years if they're receiving proper overhaul, 5 years if they're receiving proper overhauls. The other thing that happens lately in the last 10 years is technology will outdo this ventilator in 2 years. There'll be something else on the market 3 years from now that will be the new fancy gizmo gig thing that will actually, people will say, hey, this feels good, I like this. Or advancements in technology will outstrip the ventilator in about 5 years. But preventive maintenance and overhauls, 1,000 to 2,000 hours, and usually they're, I know Respironics, I think they're $600 to $1,000 each, and what they do is they replace some of the key moving parts, except for the flow generator, which is the most expensive part, and that's what burns out in them. About 5 years.
I have a second question.
Yeah.
Yep.
So when you're using the cough assist, the inexiflator, and you had talked about how does it feel, do you feel full? Do you have a maximum pressure that you usually sort of, that's the max and you don't go over?
It depends on the person. The guru, Dr. Bach, I was lucky enough to see him talk in Halifax in November. He said, if you're not using pressure at 40, you're not doing anything. But you have to get to that pressure. And actually, I was lucky enough to meet a young lady, and she was using pressures of 60 to 70, and she was comfortable with that. So through time, using it over and over again, if you have to keep getting the pressure up there, then you do what you need to do in order for the treatment to be effective. Am I comfortable with it? Not really. As a respiratory therapist, those pressures unnerve me a bit, only because through training and things, it was always, you got to keep the airway pressure down. But over time, if that's what you need and you're working your way up, then certainly, if you need to use those pressures to make it work, by all means, yeah. Yeah. But again, it's individual with the patient.
We have a question in the back.
Not actually a question. I'm just going to speak to that last comment about pressures, because my son has spinal muscular atrophy type 1, and he's actually been using the cough machine since he was 2. And under the guidance of Dr. Bach, he's actually tolerated pressures of 40 over 40 since he was 2 years old. Good. He's 13. So the question about pressures is that big, don't go too high, and but I just wanted to tell you what his tolerance has been.
No, that's great. Again, it's so individualized. It's like the masks. You got to find what's right for you. What actually works for you? If we put everyone on the same mask in the room, there'd be people that it would leak on, it wouldn't fit them. That's why there are so many masks out there and available. My job as a respiratory therapist at Quality Respiratory Care is to make sure that you get the mask that fits you, you like it, it's comfortable, it provides the treatment that you need. Any of the masks will hook up to any machine, but you got to have the mask that is right for you. You need the option. It's very important that you explore all your options, not just the mask, the machines, that sort of thing. Again, my job is to tell you this is what this machine is capable of, this is what it's supposed to do for you. Is it doing it? No. Okay, well, let's try something else. And with feedback between you and I, that's how we make it all work. Thank you.